This conference will now be recorded.
So we're going to do respiratory tonight. Um, Respiratory calls are going to be one of the highest volumes of calls we go to. A whole bunch of different conditions that can cause it. Um, Dyspnea is the medical term for shortness of breath. The cause can be difficult for you to determine. And even without a diagnosis, this is still something that you can fix at your level. So we've already done a lot of anatomy with this stuff. So hopefully some of this is review. But respiratory system consists of all the different structures that contribute to breathing. Things like the diaphragm, your chest wall muscles, the accessory muscles, and then nerves from the brain and spinal cord that run out to those muscles. Upper airway consists of the anatomic structures above the vocal cords. So that would be your nose and your mouth, your jaw, your oral cavity, your pharynx, and your larynx. There's a nice little picture. Principal function of the lungs is respiration, which is the actual gas exchange of the oxygen and the carbon dioxide. Um, Air travels through the trachea into the lungs and then moves on to the bronchi, the bronchioles, and the alveoli. The physiology of the respiration, there's two processes that occur during respiration: inspiration and expiration. Inspiration being breathing in, expiration being breathing out. Oxygen is provided to the blood and carbon dioxide is removed from the blood. In healthy lungs, the exchange of gases takes place rapidly at the level of the alveoli. So here's a photo of your alveoli showing the gas exchange. Your alveoli lie against the pulmonary capillary vessels. Oxygen will pass freely through the tiny passages in the alveolar wall into these capillaries through the process of diffusion. So if you remember way back to high school and your biology classes, cellular diffusion moving through the cell walls and things like that. After that, it's carried to the heart, which pumps the oxygen-rich blood throughout the body. Carbon dioxide will return to the lungs, and you exhale that out of your body. The brainstem will sense the level of carbon dioxide in your blood, and if the level of carbon dioxide drops too low, the person will automatically breathe slower. If the level of carbon dioxide is higher than normal, you'll start breathing rapid and more deep. So people typically think that your body will function based on the level of oxygen, and that's not the case. It's actually quite the opposite. It's the level of carbon dioxide that determines how fast or slow you might breathe. The proper exchange of oxygen and carbon dioxide can be hindered by a whole bunch of different things. Abnormal or pathologic conditions in the anatomy of the airway, some different disease processes, traumatic conditions, or abnormalities in the pulmonary vessels. As an EMT, you need to be able to recognize the signs and symptoms of inadequate breathing, and you need to know what to do for it. Carbon dioxide retention and hypoxic drive, and that's what we just talked about with the level of carbon dioxide dictating how fast or slow you breathe. Um, Sometimes patients have an altered level of carbon dioxide in their arterial blood. If the levels remain elevated for a period of years, the respiratory center in the brain may not function properly. The brain will gradually accommodate high levels of carbon dioxide and use a backup system to control breathing based on how low the levels of oxygen go. And that's known as your hypoxic drive. Um, Patients that are using their hypoxic drive, you've got to be careful giving them oxygen. You can throw their balances off too much if you give them too much oxygen too fast. Dyspnea or shortness of breath can be caused by a whole bunch of different medical problems. Um, Altered mental status can be a sign that the brain is hypoxic or lacking oxygen. Patients will often have difficulty breathing and maybe associated hypoxia with some of the following conditions: pulmonary edema, hay fever, pleural effusions, airway obstructions, hyperventilation syndrome, environmental or industrial exposure, carbon monoxide poisoning, and drug overdose. Um, Situations that can exist in a patient with shortness of breath. The gas exchange between the alveoli and the pulmonary circulation is obstructed by fluid in the lungs, an infection, or collapsed alveoli. The alveoli are damaged and can't transport the gases properly across their own walls. The air passages are obstructed by a muscle spasm, mucus, or weakened floppy airway walls. Blood flow to the lungs is obstructed by blood clots, or the pleural space is filled with air or excess fluid so the lungs can't properly expand. Table in your book that shows all the different signs and symptoms of inadequate breathing. I think we've already covered that in some of our medical assessments. Dyspnea is a common complaint in patients with cardiopulmonary disease. Congestive heart failure will cause the heart to pump ineffectively, and it deprives the body of oxygen. Severe pain can also cause a patient to experience rapid, shallow breathing without the presence of any kind of pulmonary dysfunction. Upper and lower airway infections, infectious diseases that cause dyspnea may affect all parts of the airway. Oxygenation is a problem of inadequate oxygen delivery to the tissues. The problem causing dyspnea is always some form of an obstruction. Mucus and secretions obstruct airflow in the major passages. For example, if you had a cold or something like diphtheria. Um, Swelling of the soft tissues in your upper airways, something like epiglottitis or croup. Um, Impaired exchange of gases in the alveoli, something like pneumonia. Sorry for all the noise. Um, in any case, if any patient has any of these signs or symptoms, you need to use your appropriate PPE and be aware of potential infectious disease. Um, Croup. I know we talked about croup before. We actually, when we listen to lung sounds, we listen to what croup sounds like in a kid. That's that seal barking cough that these children develop. Um, it's caused by inflammation and swelling of the pharynx, larynx, and the trachea, typically seen in children between 6 months and 3 years. Hallmark signs are the stridor and that seal barking cough. And croup often responds well to the administration of humidified oxygen. That's something that some ambulances carry. Most do not, unfortunately. Epiglottitis is inflammation of the epiglottis, and it's usually the result of a bacterial infection. It's more predominant in children, but it can occur in adults as well. Um, you're going to find your children in a tripod position, so leaning forward with their elbows on their knees, trying, really struggling to breathe. And the most important thing is they're going to be drooling. You're going to see them drooling. Um, Biggest things with that: treat them gently. Don't make them cry. Don't upset them. You've got to treat them very carefully. Position them comfortably. Give them high flow oxygen, and don't put anything in their mouths. RSV, common illness for young children, causes an infection in the lungs and the breathing passages, and eventually will lead to bronchiolitis and pneumonia. It's highly contagious, and in these patients, you're going to want to assess for signs of dehydration and treat any airway or breathing problems as appropriate. Um, Again, humidified oxygen is helpful for these patients. Bronchiolitis. This is a viral illness that occurs due to RSV and usually will affect newborns and toddlers. The bronchioles become inflamed, they swell, they fill up with mucus. For these patients, we're going to provide oxygen therapy, and we're going to frequently reassess for signs of respiratory distress. Pneumonia. Um, this is a general term that refers to an infection of the lungs. Um, it's often a secondary infection that begins after an upper respiratory tract infection. So typically you don't start out with pneumonia, you start with something, an upper respiratory tract infection of some kind, and that develops into the pneumonia. Um, Bacterial pneumonia is going to come on quickly, and you're going to have your high fevers with that. Viral pneumonia presents more gradually, and it's less severe typically. Um, Pneumonia affects people that are chronically or terminally ill a lot worse than your normal healthy person. Um, Always make sure you're checking these patients' temperatures if you would suspect they may have pneumonia. Um, Airway support and supplemental oxygen if they need it. And again, PPE, be careful. This stuff is contagious. Pertussis, or the whooping cough. Um, this is an airborne bacterial infection that mostly affects children that are younger than 6 years. Um, they're going to be feverish, and they're going to exhibit a whooping sound on inspiration after they have a coughing attack. Um, Again, very contagious. It's passed through droplets. Watch for signs of dehydration, and you might need to suction them if they have anything in their airway. Influenza type A. This is an animal respiratory disease that is mutated to infect humans. It's transmitted via direct contact with basal secretions and aerosolized droplets from coughing. Symptoms: fever, cough, sore throat, muscle aches, headaches, and fatigue. And this is one of those that leads up to pneumonia, and we're going to want to assess these patients for dehydration as well. And our favorite, COVID-19. Um, it's a virus that's very similar to the one that causes the common cold. It affects the elderly, patients that live close by to each other, and anybody with a weakened immune system. Um, Young, healthy individuals can be infected as well, just as easily as someone that's sick. Transmitted through aerosol droplets, airborne particles, things from like sneezing or coughing or direct contact. Some of the symptoms you're going to see with this: high fever, a cough, inspirational chest pain. So when they're taking that deep breath in, they feel the pain in their chest, but it goes away. Vomiting and diarrhea, and the loss of smell. Respiratory deterioration can occur rapidly with these patients. So again, support their respirations if they need it. Who's had COVID in the room, if you don't mind saying? I've had it myself. Looks like everybody but Cyrus has had it, it looks like. So lucky you. Um, Anybody have it really bad, if you're comfortable saying? Everybody have a pretty mild case? Matt's saying he had it pretty bad. When I had it, it felt like a nasty cold. It was nothing more than that for me, at least. But tuberculosis. All right, so Alex said he started out mild, and the other two times were more severe. And Matt says he felt like he was being stabbed repeatedly. So sounds like Matt got the nasty case. Tuberculosis. Was somebody saying something?
Yeah, I was gonna say, my dad got it pretty bad. He got it for a couple weeks. He had a fever of over 104, and he had an aortic aneurysm, and it made it worse. And then he had to have emergency surgery, and um, it distorted in surgery, like it fell apart when they were replacing it. So he would have died if he didn't have it then. But yeah, he got it pretty bad.
It's crazy how it affects people so differently. Some people it was just like the flu, and other people like your dad ended up like that. Well, hopefully we're over that wave, and it'll start to minimize. All right, so tuberculosis or TB. Bacterial infection, it'll most commonly affect your lungs, but it can be found in almost any other organ as well. It can be inactive for years before it produces any symptoms. Patients often will complain of a fever, coughing, fatigue, night sweats, and weight loss. Prevalence is higher with homeless people, prison inmates, nursing home residents, um, persons who abuse IV drugs or alcohol, and those with HIV. If you suspect your patient may have TB, you need to wear gloves, eye protection, and an N95 respirator. Surgical masks are not going to protect you from TB. You need to be in an N95. Acute pulmonary edema. Uh, this is a condition where the left side of the heart can't remove blood from the lung as fast as the right side delivers it. The fluid's going to build up within the alveoli and the lung tissue. Usually happens as a result of congestive heart failure. Patients will usually experience dyspnea with rapid and shallow respirations. And in severe cases, they're going to get a frothy pink sputum that comes out of their nose and mouth. Most patients will have a long-standing history of chronic congestive heart failure. Um, Typically, their heart failure is kept under control with medications. And not necessarily every patient with pulmonary edema will have a heart disease, but it is more common among the ones that do. So here's a little diagram showing the fluid filling the alveoli and separating the capillaries from the alveolar wall, which interferes with that exchange of oxygen and carbon dioxide. COPD. This is a lung disease that's characterized by chronic obstruction of the lung airflow, and it interferes with normal breathing, and it is not reversible. It's an umbrella term that's used to describe a few lung diseases, including emphysema and chronic bronchitis. Tobacco smoke is a bronchial irritant and can create chronic bronchitis, which is the ongoing irritation of the trachea and the bronchi. With bronchitis, excessive mucus is constantly produced, which will obstruct your small airways and your alveoli. The airways are weakened, and the protective cells and the lung mechanisms that remove foreign particles are destroyed. And chronic oxygenation problems can also lead to right-sided heart failure and fluid retention. Sorry, there's a really annoying air compressor next to me. Um, Pneumonia will develop easily in these patients with COPD, and repeated episodes of irritation and pneumonia can cause scarring in the lung tissues, um, which will ultimately lead to the COPD getting worse and worse. Emphysema is your most common type of COPD. Emphysema is the loss of the elastic material in the lungs as a result of chronic stretching of the alveoli. Um, Smoking will directly destroy the elasticity of the lung tissue. Most patients with COPD will have elements of both the chronic bronchitis and the emphysema. So here's the diagram showing those repeated episodes of irritation and inflammation stretching out the alveoli, and eventually it loses its elasticity. Um, One of the things with this is wet lungs versus dry lungs. Patients with pulmonary edema, caused most often by congestive heart failure, will have wet lung sounds like rhonchi or crackles, and patients with COPD will have dry lung sounds like wheezes. Uh, don't assume that all your COPD patients have wheezing and all congestive heart failure patients are going to have crackles. Treat the patient, not the lung sounds. Asthma, hay fever, and anaphylaxis. These are all different types of allergic reactions to an inhaled, ingested, or injected substance. So asthma is an acute spasm of the bronchioles, which is associated with excessive mucus production and swelling of the mucus lining of the respiratory passages. You can see in the little diagram there, um, the mucus, the airway itself starts to swell on the inside, which creates a smaller opening, and then you get the mucus on top of that, which makes it even smaller, making it hard for the patient to move air. Asthma will affect patients of all ages, but it's most prevalent in children 5 to 17 years of age. It produces the characteristic wheezing as the patient tries to exhale, and that wheezing noise is caused by that thinned airway passage. Acute asthma attack may be caused by an allergic reaction to specific foods or other allergens. Attacks can be caused by emotional distress, exercise, and other respiratory infections. In its most severe form, the allergic reaction can turn into anaphylaxis. Hay fever, it causes cold-like symptoms, runny nose, sneezing, congestion, sinus pressure. Um, the symptoms are caused by an allergic reaction, usually to outdoor airborne allergens. Anaphylactic reactions. This is a severe allergic reaction that's characterized by severe airway swelling and dilation of the blood vessels all over the body. May be associated with widespread hives, itching, signs of shock, and signs and symptoms similar to asthma. So in anaphylaxis, you're getting that airway swelling. You're going to start to hear some of the same lung sounds, but a lot of times it's going to be characterized with those rashes or hives all over the body. Epinephrine is the treatment of choice. Oxygen and antihistamines are helpful. So patients that are having a severe reaction are going to need epi. If they're having a more minor reaction, they might get away with something like Benadryl. Spontaneous pneumothorax. So the pneumothorax is a partial or total accumulation of air in the pleural space. Most often, this is going to be caused by trauma, but it can be caused by a medical condition, which would be your spontaneous pneumothorax. It's a vacuum-like pressure in the pleural space. It keeps the lungs inflated. When the surface of the lung is disrupted, air escapes into the pleural cavity, and the negative vacuum pressure is lost. Spontaneous pneumothorax occurs in patients with certain chronic lung infections or in young people born with weak areas of the lung. A patient with a spontaneous pneumothorax will become short of breath. They might complain of pleuritic chest pain. Their breath sounds are going to be absent or at least decreased on the affected side. And they have the potential to evolve into a life-threatening pneumothorax. A pleural effusion. So this is a collection of fluid outside of the lungs. It's going to compress the lungs and cause shortness of breath. Could be caused by an irritation, an infection, congestive heart failure, or cancer. The breath sounds are going to be decreased over the area where the effusion is present, and patients are going to feel better if they're sitting upright. An obstruction of the airway. Patient with shortness of breath may have some kind of a mechanical obstruction. With semi-conscious and unconscious patients, the obstruction may be the result of aspirations of vomit or a foreign object or food. Could be improper positioning of the head as well. If you think of a child and the size of the child's tongue versus the size of a child's airway, it doesn't take much for the tongue to actually cover up the airway and cause them to have an obstruction like this. If the patient was eating just before the onset of their shortness of breath, always consider the possibility that there's a foreign body obstruction in their throat. So the foreign body obstruction is an object like food that's lodged in the airway. Mechanical obstruction can also occur when the head's not properly positioned, which causes the tongue to fall back onto the throat. Pulmonary embolism. An embolus is anything in the circulatory system that moves from its point of origin to a distant site and lodges there, which obstructs the subsequent blood flow to that area. Your circulation can be cut off completely or just partially. And the emboli can be fragments of blood clots in an artery or vein that break off and then travel through the bloodstream, something like a bubble of air. Pulmonary embolism is a blood clot that circulates through the venous system and the right side of the heart, and then it lodges in your pulmonary artery. Some of the signs and symptoms of a pulmonary embolism: short of breath, tachycardic, tachypnea, varying degrees of hypoxia, cyanosis, acute chest pain, and hemoptysis. Anybody know what hemoptysis is? It's when you're coughing up blood. If you have a large enough embolism, complete obstruction of the output of blood from the right side of the heart can result in sudden death. Hyperventilation. So this is overbreathing to the point that the level of arterial carbon dioxide falls below normal. Could be an indicator of a life-threatening illness. The body might be trying to compensate for acidosis, the buildup of acid in the blood or body tissues. Can result in alkalosis as well. Can cause symptoms of hyperventilation syndrome or panic attacks. Things like anxiety, dizziness, numbness, tingling in the hands and feet, painful spasms of the hands or feet, which are called carpopedal spasms. And the decision whether hyperventilation is being caused by a life-threatening illness or a panic attack shouldn't be made outside of the hospital. Just because it looks like the patient's having a panic attack, there could be a medical cause behind that as well. Environmental or industrial exposure. So things like pesticides, cleaning solutions, chemicals, chlorine, other gases, they can accidentally be released at industrial sites and inhaled by the employees. Doesn't have to be an industrial site for this. It can happen just about anywhere. Carbon monoxide poisoning. Carbon monoxide is an odorless and highly poisonous gas. It's the leading cause of accidental poisoning deaths in the U.S. Carbon monoxide is produced by fuel burning household appliances, and it's also present in smoke. People who have carbon monoxide poisoning will complain of flu-like symptoms and even shortness of breath. Always make sure you're not putting yourself at risk. And we're going to treat these patients with high flow oxygen with a non-rebreathing mask. I think we talked about this before too, but anytime you go to a house and you have multiple patients that are all complaining of very similar symptoms and they're flu-like symptoms, you should always be suspicious that there might be something bigger going on to create multiple patients like that. And again, carbon monoxide is colorless, odorless. Aside from having a carbon monoxide meter, there's no way to determine if it's present in the atmosphere. Scene size up. Always use your standard precautions in your PPE. Consider the possibility of an infectious disease or a toxic substance. And again, if there's multiple people with shortness of breath, consider the possibility of an airborne hazardous material release. You can always ask why 911 was activated if you're questioning the mechanism of illness or the mechanism of injury, the nature of the illness. You can question the patient, family, bystanders. You should be able to determine that. So when we're assessing these patients, our primary assessment, like always, the biggest thing is identifying any immediate life threats. We're gonna form an overall general impression of the patient's level of distress. You should note the age and the position of the patient. Use your AVPU scale to check for their responsiveness, and then ask the patient about their chief complaint. Assessing the ABCs, make sure the airway is patent and adequate, and evaluate whether or not the patient's breathing is adequate. looking for the rate, rhythm, and quality of their breathing. And ask yourself, is the air going in? Does the chest rise and fall with each breath? And is the rate adequate for their age group? Assess their breath sounds. Make sure you're checking both sides, left and right. Um, you're looking for any abnormal sounds like wheezing, rales, rhonchi, stridor, um, all those different sounds we listened to a few weeks ago. For the circulation, you're going to assess the pulse, rate, rhythm, and quality. You're going to evaluate them for any shock-like symptoms and any major bleeds, and you're going to assess their perfusion by evaluating their skin color, temperature, and condition. You're going to make a transport decision. So if they're unstable and there's a possible life threat, address that threat as best you can and proceed with rapid transport. For your history taking, you're investigating their chief complaint. Um, determine what the patient's already done for the breathing problem, especially if they have a history. Have they already used their own inhaler? Have they used a nebulizer? Have they taken any medications? Um, Sample history, if they're short of breath and there's a knowledgeable family member there, this is a good time to let the family member talk as much as possible. Don't make your shortness of breath patient talk any more than they have to. Use your OPQRST, and you can use this the PACE assessment. That's yet another acronym for you. Progression, associated chest pain, sputum, talking tiredness, and exercise tolerance. You should only proceed with your secondary assessment if you've treated all the life threats. Um, and if you have them, use monitoring devices, things like capnography, SpO2, SpCO, all those different tools. Make sure you're looking for signs of COPD in the patients. Your COPD patients are usually going to be older than 50. They typically have a history of lung problems. They're almost always long-term active or former cigarette smokers. They'll complain of tightness in the chest and constant fatigue. Um, their chest may have a barrel-like appearance. So these patients that have long-term COPD, their chest actually will start to expand. Um, they're going to use accessory muscles frequently to try and breathe. They're going to have abnormal breath sounds. You might see them exhale through pursed lips. So if you imagine you had a straw between your lips and you try to breathe in and out like that, that's called pursed lip breathing. And they might have digital clubbing, which is enlargement of the ends of the fingertips. For your reassessment, you're going to repeat your primary assessment, find out if there have been any changes in the patient's condition. You're going to confirm that your interventions are adequate for the patient's status. Um, you're going to provide oxygen via a non-rebreathing mask at 15 liters per minute for a patient with respiratory distress. You may have to step that up and give positive pressure ventilations with a bag mask. You may need an OPA, an NPA. You may need to suction. You may need to just open the airway. You may need to position it correctly. You might use CPAP, positioning the patient in a high Fowler position or a position of their choice. Patients with shortness of breath, we shouldn't be laying them flat. Communicate any of the relevant information to the staff at the hospital when you get there. Emergency medical care for these patients with shortness of breath. Again, oxygen support immediately. A lot of times, you've got to judge it based on how the patient presents. Typically, you want to start lower and work higher. So if they're not severely short of breath, you may want to start out with a nasal cannula. If that's not having the desired effect, then you step it up to a non-rebreather. If that's not having the desired effect, you can step up to a CPAP or a BVM. You've got to use your discretion and determine the patient's status and how severe their difficulty breathing is. Um, if the patient's mental status starts to decline, or if they're in moderate to severe respiratory distress, you've got to keep an eye on their respiratory status. You've got to make sure they're still breathing on their own. Provide emotional support to them. Keep them calm. Patient may have a meter-dosed inhaler or a small volume nebulizer. You can consult medical control, and if it's within your protocols, you can help them administer their own nebulizer or meter-dosed inhaler. Ensure there's no contraindications with the patient's condition before they get any meds. Um, Most respiratory inhalation medications are used to relax the muscles surrounding the air passages in the lungs, which will ultimately dilate the airway. Some of the common side effects when they are using their inhalers, you're going to see an increased pulse rate. They're going to get nervous. They're going to have muscle tremors. They might get jittery. Um, when they use an inhaler, the medication's delivered through the respiratory tract into their lungs. And in your book, there's a couple skill drills that'll show you how to use an inhaler and a small volume nebulizer. That stuff we'll do on our in-person days. We'll go over how to use those different items. Treating specific conditions. So upper and lower airway infections. If you have that humidified oxygen, that's great for these patients. Don't try to suction them or place in an OPA if the patient might have epiglottitis. You don't want to irritate that any further. Put them in a position of comfort and transport them right away. Pulmonary edema. We're going to give them 100% oxygen, suction them if they need it, put them in a position of comfort. If it's indicated, CPAP is good for these patients, and transport them promptly. COPD, if they have an inhaler, assist them with it. Watch for the side effects due to overuse, the things we talked about, like the increased heart rate, the jitteriness, things like that. Put them in a position of comfort and transport them promptly. Asthma, hay fever, and anaphylaxis, be prepared to suction them. If it's an asthma patient, they're probably going to have an inhaler. Hopefully they have it on them. You can assist them in using that. And be aggressive with your airway management. Transport them right away. Patients with hay fever, typically they don't need emergent transport. Manage their airway, give them oxygen according to their level of distress. Again, that's one where we can start out simple, and if that's not working, we gradually move up to the next step. Anaphylaxis, remove the offending agent. If it's a bee sting and the stinger's right there, you can remove that. Aggressively manage their airway, give them oxygen, transport them right away, and these patients need to get epinephrine. That's ultimately what's going to fix their problem. Spontaneous pneumothorax, give them oxygen, transport them right away, monitor them carefully. Pleural effusion patients, ultimately they need their fluid removed, and that's something that can only happen in the hospital. So give them oxygen and transport them promptly. Airway obstructions, if it's a partial obstruction, provide supplemental oxygen and transport them. If it's a complete obstruction, you've got to clear that obstruction and give them oxygen. Be that by the Heimlich maneuver. If it's something you can see obviously in the mouth, you can remove that. We do not do blind finger sweeps anymore. We don't dig around in their mouth and throat and try to find things. If it's something you can obviously see, you can pull it out. If you can't see it, don't go trying to find it. Use things like the Heimlich. And again, transport them rapidly. Pulmonary embolism, they need supplemental oxygen. Position them comfortably. If they're coughing up blood, make sure their airway's clear. You might need to suction them, whatever you need to do, and transport them promptly. Patients with hyperventilation, complete your primary assessment, gather their history. Do not have them breathe into a paper bag. We don't do that. Reassure the patient, give them supplemental oxygen, and transport them right away. A lot of times with these patients, it's a matter of talking to them, making them feel comfortable, and just calming them down. And your environmental exposures. Make sure your patients are deconned. We've already talked about that. Don't contaminate yourself, the ambulance, the hospital, all that good stuff. Um, make sure you're not. Siri's yelling at me. Make sure you don't don't contaminate yourself or your partner or bystanders or other responders, stuff like that. If you suspect there's carbon monoxide present, back out of the scene and make the right calls. Don't try to be a hero and run into situations where you're going to get yourself hurt. You're not doing your patients any good if you yourself end up being a patient. These patients that are exposed, give them oxygen, use an airway adjunct if you need it. If they need suction, use it and transport them right away. If they aspirate a foreign body, perform the appropriate airway clearing technique specific to their age. So whether that's the Heimlich, I know we haven't done CPR yet, but that's part of the CPR class. We'll talk about different ways to clear the airway. And that could be as simple as if it's an adult, putting them in the recovery position, putting them on their side so they can kind of clear their own airway if it's filled with vomit or anything like that. Give them oxygen and transport them. A patient that has a tracheostomy, which is that hole in the front of their throat, if they have some kind of a dysfunction with that, position them comfortably. Um, you can provide suctioning, and once the obstruction's clear, you can oxygenate the patient. Um, I don't believe it's within New Hampshire protocols at the BLS level to actually suction out a patient's tracheostomy. Um, you can actually remove the cap, and you can use a flexible suction catheter to get all that mucus out of their throat, and that'll help them breathe better right off the bat. Once that obstruction's cleared, you're going to want to oxygenate them. We talked about that a little bit before, where you can use a pediatric non-rebreathing mask and put it over the hole in their throat. Um, when you're doing that, they're going to need to block their nose and mouth so that the air is actually going down into their body and not escaping. Asthma patients, if it's a child, try to give them blow-by oxygen. You can do that by holding a mask in front of their face. Um, we all know how children react. If you come running at them with a mask and try to strap something to their face, it's probably not going to go well, especially if they're not feeling well. You've got to be very careful. You've got to be slow and methodical with this. You've got to talk to them. You've got to make them feel comfortable. And I mean, the ultimate goal is to get them some oxygen. So whatever you need to do to make that happen. And a lot of times, if mom's there or dad's there and they're comfortable with mom or dad, hand the mask to mom or dad and have mom or dad hold it. Chances are they're going to be more comfortable with that. Um, as with any chronic disease, asthma may become life-threatening in a patient that's older. Cystic fibrosis. This is a genetic disorder that will affect the lungs and the digestive system. It'll predispose a child to repeated lung infections. The symptoms can range from sinus congestion to wheezing and asthma-like complaints. Uh, Suction their airway if they need it. Give them oxygen if they need it. We whipped through a lot. Does anybody have any questions about what we've done so far? All right, hearing nothing, let's go into the review. Use the chat box like normal. The process in which oxygen and carbon dioxide are exchanged in the lungs is called what? Very good. A, respiration is the gas exchange. Which of the following respiratory diseases causes obstruction of the lower airway? Very good. B, Asthma is your lower airway disease. Which of the following diseases is potentially drug resistant and is thought to be transmitted by coughing? Good. A, tuberculosis. This is your bacterial infection that's spread by the cough, and it is antibiotic resistant. All of the following are causes of acute dyspnea except for what? All right, so this one is B. Emphysema, which is a form of COPD, is a chronic respiratory disease. Therefore, it's progressively worsening. The other three are acute. So the difference here was chronic versus acute. Bronchospasm is most often associated with what? All right, so this one, the answer was A or 5. I don't know why they're numbers and not letters, but asthma is a reactive airway disease. It is caused by that bronchospasm. Sudden onset of difficulty breathing, sharp chest pain, and cyanosis that persists despite the supplemental oxygen is consistent with what? So this one's actually C. The key was the sharp or the pleuritic chest pain. Um, and the cyanosis, even with the oxygen, is not going to go away. Even with a myocardial infarction, the cyanosis will go away with oxygen. It will not in a pulmonary embolism. Albuterol, which is a beta 2 agonist, is the generic name for what? I don't, we didn't cover this, so I'm not sure why this is a review question, but give it your best guess, I guess. I like it, Kyle. All of the above. The answer is Ventolin, um, or Prevental. That's the generic. Again, that was not covered in the slides. I don't know why that's a review question. I'm sorry. An acute bacterial infection that results in the swelling of the flap that covers the larynx during swallowing is called what? All right, good. C, epiglottitis. That little flap is called the epiglottis. So, 70-year-old man recently had a heart attack. He now complains of severe difficulty breathing, especially when he's lying flat. He's coughing up pink, frothy secretions. This patient is most likely experiencing what? All right, B, left-sided heart failure. Which of the following patients would be considered to be breathing adequately? All right, very good. The answer was B. That one's pretty obvious. All right, that's it for that one. Um, let's take 10 minutes. Be back in 10.
This conference will now be recorded.
So now we're going to do allergy and anaphylaxis. This ties very closely into what we just covered. So a lot of the information is going to be very similar. So hopefully it's a quick and easy one for us. EMTs often respond to calls involving allergic reactions. Um, like we just talked about, the emergencies involve acute airway obstructions and cardiovascular collapse. Um, you must be able to treat the life-threatening complications, and you must also be able to distinguish between the body's usual response to an allergen and an allergic reaction. This chapter is going to describe immunology, which is the study of the body's immune system, and the 5 categories of stimuli that may provoke an allergic reaction. So the immune system protects the body from foreign substances and organisms. When a foreign substance invades the body will initiate a series of responses to inactivate the invader. Allergic reaction is an exaggerated immune response to any substance. Um, it's not caused directly by an outside stimulus like a bite or a sting. It's caused by the body's immune system, which releases chemicals to combat the stimulus. These chemicals include histamines and leukotrienes, both of which contribute to the allergic reaction. Some patients aren't going to know what's causing their allergic reaction, so you're going to need to be able to recognize signs and symptoms and maintain a high index of suspicion for different things. Uh, Allergic reactions can be mild and local, which are characterized by itching, redness, and tenderness, or severe and systemic, which is your anaphylaxis. Anaphylaxis is your extreme life-threatening allergic reaction. It involves multiple organ systems, and it can rapidly result in shock and ultimately death. Those are the hives we talked about earlier. So they're those like raised red bumps. Some other signs of anaphylaxis: angioedema, areas of swelling. So there's a giant tongue for you. Also, the wheezing that we talked about earlier, you're going to hear that high-pitched whistling breath when they exhale. You may also note stridor on inspiration due to the narrowing of the upper airway. They might be hypotensive due to the vasodilation and the increased capillary permeability. They might be nauseous, they might be vomiting, and they might have abdominal cramps. Some of the common allergens could be food. Food may take more than 30 minutes to appear. Shellfish and nuts are two of the very common ones there. And with food, you may not have the hives. You may not see the skin symptoms as well. The reaction can be severe and involve the respiratory, and the cardiovascular systems as well. Also medications, things like antibiotics and NSAIDs. If a medication is injected, the reaction can be immediate and severe. Reactions to oral medications may take more than 30 minutes to appear, but they can still be very severe. Plants, dust, pollen, other plant materials can cause a rapid and severe allergic reaction. Common plant allergens include ragweed, ryegrass, maple, and oak. Chemicals, certain chemicals, makeup, soap, hair dye, and latex, and other substances can cause severe allergic reactions. Um, Latex is particular concern for us as healthcare providers. Um, I don't think there's anybody out there that's still actually using latex gloves. Most of them are nitrile now, but there are latex materials used in the healthcare setting, so you've got to be aware of that. Insect bite and stings, an envenomation, which is the process of an insect injecting its venom. The reaction can be localized or it may be severe and systemic. Approximately 2 million Americans are allergic to the venom of bees, wasps, and hornets, and allergic reactions to insect stings account for at least 62 deaths in the US per year. In about half of those deaths, the victim had never had a reaction prior. The stinging organ of most insects is a small, hollow spine which projects from the abdomen. Honeybees cannot withdraw their stinger, and if the stinger is not removed, it can continue to inject venom for up to 20 minutes. And wasps and hornets can sting multiple times. Some ants, especially the fire ant, can strike repeatedly. Some of the signs and symptoms you're going to see with these: sudden pain, swelling, localized heat, The widespread urticaria, those bumps, redness in light-skinned individuals, itching, and possibly the wheals. In severe anaphylactic cases, the patients can also experience stridor, bronchospasm and wheezing, chest tightness and coughing, dyspnea, anxiety, GI complaints, and hypotension. Occasionally, patients can experience respiratory failure. Um, if untreated, an anaphylactic reaction can proceed rapidly to death. More than 2/3 of patients who die of anaphylaxis do so within the first 30 minutes. Our patient assessment: size up your scene, check for scene safety. Um, if you're allergic to bees and you're going to a bee sting, obviously you want to be very careful. There's probably going to be bees around. Same thing with snakes, spiders, any of that good stuff. Thankfully, we don't have much of that around here. Respiratory problem reported by dispatch may be an allergic reaction. Um, until you've established that there's a field impression of an allergic reaction, be mindful of other potential causes of respiratory distress. Traumatic injury may also be present secondary to the medical emergency. Follow your standard precautions with a minimum of gloves and eye protection, and consider the need for additional resources such as ALS. Quickly identify and treat any immediate or potential life threats. ABC should be reassessed repeatedly throughout the transport. Form your general impression. Allergic reactions may present as a respiratory condition or as cardiovascular distress in the form of shock. If the patient is anxious and in distress, immediately call for ALS backup. Look for medical identification tags if the patient's unresponsive or unable to answer questions. Medical identification tags, I don't remember if we've talked about this yet. Used to be as simple as they'd wear a necklace or a bracelet, but nowadays it could be just about anything. People are getting tattoos, could be information on their phone. So you got to look around, you got to use your resources around you to try and find out if there's any information available to you. Assessing their airway and breathing. Anaphylaxis can cause rapid swelling in the upper airway, and not every allergic reaction is necessarily anaphylaxis, so you need to know the difference and differentiate between them. You want to quickly assess for increased work of breathing, use of accessory muscles, head bobbing, tripoding, flaring of their nostrils, and abnormal breath sounds. Assist the patient into a position that's comfortable for them, generally a high Fowler position to maximize their ventilations. Again, a patient with difficulty breathing, we don't lay flat. We keep them sitting up. If signs of shock emerge, immediately place the patient in the supine position as tolerated. So if they're getting shocky, that's when we're going to try to want to lay them flat. Again, if laying them flat is going to cause them to not be able to breathe, we need to sit them up. For a patient in severe respiratory distress, you may have to assist their ventilations using a bag mask device attached to high flow oxygen. Some patients in anaphylaxis may present with signs and symptoms of circulatory distress, such as hypotension, and you want to assess for signs of hypoperfusion. You can do that by looking at their skin color, condition, quality. Check their cap refill. Treat them for shock. The definitive treatment for anaphylactic shock is epinephrine. Back to epinephrine for a minute. During one of our classes, we'll go over ready, check, inject. So most ambulances are no longer carrying EpiPens. They're insanely expensive, and getting epi in a vial is incredibly cheap. So most ambulance services have moved to that. So you actually need to know how to draw it up and inject it that way versus just using an EpiPen. So during one of our in-person classes, that's something we'll cover. Making a transport decision. If you suspect anaphylaxis, or if it's a relatively mild allergic reaction that appears to be worsening, they need to be transported immediately. If the patient's calm and doesn't exhibit any severe symptoms, continue the assessment on scene, but always err on the side of emergency transport. History taking, investigate their chief complaint, identify their signs and symptoms. A whole bunch of different additional symptoms of allergic reactions. Just about anything: sneezing, itchy, runny nose, shortness of breath, tightness in the chest and throat, persistent dry cough, hoarseness, rapid, labored, or noisy respirations, and wheezing. Increase in their pulse rate, red, flushed, hot skin, or pale cyanotic cool skin. Um, Decrease in their blood pressure, flushing, itching, burning skin, the urticaria over large areas of the body, swelling of the face, neck, hands, and feet, and then of course the tongue, cyanosis or pallor around their lips, uh, warm tingling feeling in the face, mouth, chest, feet, and hands. Their mental status may start to decrease. They may be anxious. They may start to have GI problems such as nausea, vomiting, or cramps. They may develop a headache, itchy, watery eyes, or dizziness. Take your sample history. If you can do it, ask if they've had any interventions, and ask if they've ever had a severe allergic reaction in the past. And like we talked about earlier, just because they haven't had a severe allergic reaction in the past doesn't mean they aren't currently. Um, be alert for any statements they might make regarding ingestion of foods that can cause allergic reactions. Ask them about any GI complaints like nausea or vomiting. Physical exam. With all of these patients, you need to actually examine them because you need to look for the different rashes and things like that they might have from these conditions. Those aren't necessarily always going to appear on their hands or their arms where you're going to be able to see. It can happen on their back. It can happen on their legs. So you need to actually assess them and look for that kind of thing. You need to listen to their lung sounds and see what you hear. Check their vitals, pulse and respiratory rates, blood pressure, pupillary response, their oxygen saturation. Um, their skin signs may be unreliable indicators for hypoperfusion. They may vary widely, or it might be hidden by their rashes and swelling. Use your pulse oximetry if you have it. And the decision for oxygen should be based on the patency of their airway, their work of breathing, and any lung sounds you might hear, not just on their pulse oximetry readings. So that's back to treat the patient, not the machine. Just because the machine says their pulse, or I'm sorry, their oxygen saturation is good, it's in normal range, but they're still short of breath, give them the oxygen. Again, reassessing. If they're unstable, you're reassessing every 5 minutes. If they're stable, you can reassess them every 15. You're going to be watching for signs of shock. You're reevaluating anything that you've performed, any treatments you've provided, or anything like that. As far as your interventions, determine how severe the reaction is. Mild reactions are just going to require supportive care and monitoring. Anaphylaxis is going to require you to give them epinephrine and maybe even support their ventilations. Transport them to a hospital and recheck your interventions throughout. Is everybody's screen kind of going weird, or is it just mine? Give me a thumbs up if you can still see the PowerPoint. Okay. Communication and documentation. Make sure you're documenting all the signs and symptoms, any reasons that you provided the care you did, and their response to the treatments. If the patient appears to be having a severe allergic or anaphylactic reaction, Start out with your BLS treatments and provide transport to the hospital promptly. We talked about this with the bee stings. If the stinger is still present, you can use the edge of a sharp, stiff object, a credit card or something similar, and you can actually scrape that to remove the stinger from the patient. Like we talked about earlier, the stinger can continue to release everything. I don't know what keeps happening to the screen. Can you guys still see the PowerPoint? Sorry, guys, just give me 1 second here. All right. As I was saying, the stingers, if they have a stinger that's still present, it can continue to release the toxins for up to 20 minutes. So if it's still there, try and scrape it out. Don't use tweezers or forceps to try and get it out. You'll end up just breaking it off, and it causes more problems from there. Use the credit card or something similar to scrape it. After the stinger's out, you can wash the area with soap or antiseptic if you have it. If they have any jewelry, like if they get stung on the arm and they're starting to swell up, if they have any rings on or anything like that, take them off while you still can. Eventually, they're going to swell up to the point that you can't remove them. Your injection site, if you're going to give epinephrine, it needs to be below the heart. And if they have swelling or anything like that, you can apply ice or cold packs to help reduce that swelling. Make sure you're alert for signs of airway swelling and any other signs of anaphylaxis like nausea, vomiting, abdominal cramps, all that good stuff. We don't give patients anything by mouth. Place the patient in the supine position as indicated. Again, be alert for their difficulty breathing. Monitor their vital signs. Be prepared to provide further treatments as needed throughout the transport. Epinephrine, it mimics the sympathetic or the fight or flight response. It causes the blood vessels to constrict, which will reverse vasodilation and the hypotension. Other properties of epinephrine are increasing cardiac contractility and relieving bronchospasm in the lungs. It can rapidly reverse the effects of anaphylaxis. Epinephrine is prescribed by a physician, and it typically will come pre-dosed in the automatic injector or an EpiPen. Some EMS systems are authorized to carry epinephrine as part of their regular onboard medications. In others, EMS providers may be permitted to help patients self-administer their own medications. Use your local protocols. New Hampshire and Maine, you can both give it off the ambulance. And like I said, we'll cover the ready, check, inject because that's how most services are doing it now. Here's a little photo showing how the EpiPen would actually work. When you're giving an EpiPen, you're using the side of the thigh. It will go through pants. It's got a pretty long needle in there. Something very important about epinephrine, if you have a way to write this down, I highly recommend you do. There's 2 doses for epinephrine, and you need to know them. 0.15 milligrams is for children, and 0.3 milligrams is for adults. That's something you're going to need to remember. It will come up again. 0.3 for adults, 0.15 for kids. Side effects of epinephrine, high blood pressure, increased pulse, anxiety, can cause cardiac arrhythmias, can cause pallor, dizziness, chest pain, headaches, nausea, vomiting. Um, Patients that do not have signs of respiratory compromise should not get epinephrine. If they don't have anaphylaxis, if they're not to that point yet, they don't need epinephrine. And we've hit our review. The signs and symptoms of an allergic reaction are caused by the release of what? Very good. The answer is D. Negative effects associated with anaphylactic shock are the result of. Cyrus, I'm not sure. It might be if you have bad service, that could be why, but I can't see everybody's answers. All right, so the answer for that one was C. You're called to a local baseball park for a 23-year-old man with difficulty breathing. He states that he ate a package of peanuts approximately 30 minutes ago and denies any allergies or past medical history. Your assessment reveals widespread urticaria, tachycardia, and a blood pressure of 90/60. You can hear him wheezing even without a stethoscope. You should be most suspicious of what? Very good. C. Starting to develop the signs and symptoms of an anaphylactic reaction. What is a wheal? Very good. A. It's that raised area on the skin. You're treating a woman who was stung numerous times by hornets. On assessment, you note that some of the stingers are still embedded in her skin. What should you do? All right. So remember, with this one, the venom can keep coming out for up to 20 minutes. So we're gonna do that scraping method with these with the credit card. Excuse me. Young male is experiencing signs and symptoms of anaphylactic shock after being stung by a scorpion. His level of consciousness is diminished. His breathing is severely labored. You can hear inspiratory stridor, and his face is cyanotic. The patient has a prescribed epinephrine autoinjector. What should you do first? So I'll caution you with this one. This is one of those National Registry style questions where you're looking for the most correct answer. And typically, when you're looking for the most correct answer, remember we start with ABCs, airway, breathing, and circulation. So the correct answer for this one was C, ventilatory assistance with a bag mask device. So his level of consciousness is diminished and his breathing is severely labored. So both of those things tell you that he's bordering respiratory failure. So we're going to want to assist him with a bag mask device. Again, you're all correct in that ultimately the next step, step number 2, is going to be giving him the epinephrine. But we always consider the ABCs to be our first priority. So the correct answer was C. Most reliable indicator of upper airway swelling during a severe allergic reaction is what? Very good. A, stridor. The lung sounds are going to be your best indicator of airway swelling. Most common trigger for anaphylaxis is what? Good. D. So food is your most common trigger for anaphylaxis. Told you it was going to come up again. The adult EpiPen system delivers how much epi, and the infant child system delivers how much epi. Very good. B. 0.3 for adults, 0.15 for children. All right. So when you're giving epi with an auto injector, how long should you hold it in place for? All right, B, 10 seconds. So you want to hold it for 10 seconds to make sure all of the medication makes its way in. All right, another one down. A couple weeks ago when we canceled class, we missed 2 PowerPoints. So where it's still relatively early, I'm going to try and squeeze one more of those PowerPoints in tonight. So let's take a 5-minute break. I'll queue up the next one and we'll plow through one more.
This conference will now be recorded.
All right, so patients who need EMS assistance generally have experienced a medical emergency, a trauma emergency, or both. Uh, Traumas are going to be your injuries that result from physical forces applied to the body, and medical emergencies involve illnesses or conditions caused by disease. It's important to remember that patients may have a combination of both. Respiratory emergencies occur when patients have trouble breathing or when the amount of oxygen supplied to the tissues is inadequate. Cardiovascular emergencies are caused by conditions affecting the circulatory system. Neurologic emergencies involve the brain. Gastrointestinal conditions include appendicitis, diverticulitis, pancreatitis, and many others. Urologic emergencies can involve kidney stones. Most common endocrine emergencies are caused by complications of diabetes. Hematologic emergencies may be the result of sickle cell disease or different types of blood clotting disorders like hemophilia. Immunologic emergencies involve the body's response to foreign substances. Toxicologic emergencies, including poisoning and substance abuse, uh, and result in other types of medical emergencies. Some medical emergencies are caused by psychological or behavioral problems, and those may be especially difficult to deal with because patients don't present with typical signs and symptoms. Gynecologic conditions are a special category of medical emergencies, and that's things that involve the female reproductive system, and childbirth and such would be categorized under that. Here's a quick table with some common medical emergencies. I know we're a little out of sequence, but I think we've covered most of these emergencies already. Um, Assessment of the medical patient is similar to the assessment of the trauma patient, but with different focuses. The medical patient assessment is focused on the nature of the illness, the symptoms they present with, and their chief complaint. So you're looking to establish an accurate medical history. You're going to use dispatch information to guide your initial response, but don't get locked into a preconceived notion of the patient's condition. Just because you're dispatched to one thing doesn't mean that's what you're going to see when you get there. You've got to be aware that there could be other things going on. The patient's injuries might distract you from their underlying problem, and tunnel vision occurs when you become focused on one aspect of the patient's condition and exclude everything else. This can cause you to miss an important illness or injury. You've got to stay open-minded to what might be going on. Your assessment may be difficult with uncooperative or hostile patients. You need to maintain a professional, calm, non-judgmental demeanor at all times. Refrain from labeling your patients and displaying any biases. A frequent caller may have a different complaint this time. Um, I'll give you a quick little story on that one. We had a frequent flyer who we were seeing 2 or 3 times a shift every week up in the area I work. And we got to the point where we were all so fed up with this patient that we immediately just wrote her off, and it's just this individual acting the way they act. Well, that can turn around really quick, and one of the times that this individual called for us, she was actually experiencing a pretty significant medical condition. She was actually having a cardiac condition, and had had the crews had the bias of it's just her being her, they may have missed that. They may have missed that she actually had a cardiac condition and she was actually sick, and she may have not gotten the care she needed. Although it might be difficult, although some of our callers might be frustrating, you've got to treat them like a new patient every time. You've got to be open and don't develop a bias against a patient just because they call frequently. Scene size up. Always make sure you're seeing safe for you, your crew, and your patient. Use your standard precautions, determine the number of patients and whether or not you need extra help. Determine the nature of the patient's illness. The index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries or illness. Um, Always consider spinal immobilization for medical and trauma patients. Develop your general impression. So you're going to perform a rapid exam of the patient to identify any life threats. Quickly determine the patient's level of consciousness using your AVPU scale. Airway and breathing. In conscious patients, ensure their airway is open and they're breathing adequately. Check the respiratory rate, depth, and quality. Consider giving them oxygen if their breathing has been affected. For unconscious patients, make sure to open the airway using the proper technique and take several seconds to evaluate their breathing. Apply oxygen to patients if they need it. If they're in shock, if they have difficulty breathing, or if their oxygen saturations are low, less than 94%. Unconscious patients need ventilatory assistance with a bag mask device, and they may also need an airway adjunct to hold their airway open. For your circulation, in a conscious patient, check their radial pulse, observe their skin color, temperature, and condition. If they're unconscious, assess the circulation by the carotid artery by checking their pulse. Develop your transport decision, excuse me. Patients that are in a serious condition need rapid transport. They need to go to the hospital right away. Spend less time on scene asking questions and spend more time getting them ready to get in the truck and go. When you're in the truck, that's when you can ask these questions. Any patient who's unconscious or has an altered mental status, any patient with an airway or breathing problem, any patient with a circulation problem such as bleeding or signs of shock, they all need rapid transport. If the patient is not severe, you can continue your assessment on scene and prepare for transport when you've completed your assessment and any treatments. So we call that the sick, not sick determination. So you're determining whether they're sick and need that immediate transport, or they're not sick and you have a few minutes to do the things you need to do before you go. So during your history taking, your goal is to determine what the problem is or what might be causing the problem. And you can do that by gathering a thorough history. Investigate the nature of the illness by inquiring about their chief complaint. For an unconscious patient, survey the scene. Look for medication containers, medical devices, any kind of drug paraphernalia, anything that might be around them that might indicate what was happening before they became unconscious. Obtain your sample history. Use your OPQRST mnemonic. You want to record any allergies, medical conditions, and any medications they're taking. A lot of people maintain their own medication lists, so just ask them, do you have a list of your medications? If they don't, give them homework. Encourage them. Hey, hopefully we don't ever have to come pick you up again, but if we do, have a list of medications ready to go. It'll help us out. And allergies are important because you might give them a medication and you need to know if they have any allergies to medications before you introduce anything new to them. Some patients take numerous medications. It says to take the medications with you to the hospital. I like to send them with a family member instead of taking them myself. I don't like the risk of them getting lost or falling out of the truck when you open the door or the hospital losing them when you get there. I prefer to send them with a responsible family member, but do what you need to do. Your secondary assessment. So this might occur while you're on scene or while you're en route to the hospital. Again, that's going to be determined based on your sick, not sick. In some cases, you might not have time for your secondary assessment. If you have a patient that's in really critical condition and you're going to be putting all your focus on their airway and their breathing, you might not have time to do a secondary assessment. Your secondary assessment needs to be a physical exam. Conscious patients should undergo a limited or detailed physical examination based on their chief complaint. If they're having chest pain, you need to touch their chest. You need to push on their chest and see if things change. You need to actually touch your patients in an appropriate manner to assess them correctly. Unconscious patients, they need a secondary assessment of their entire body. They need a head-to-toe examination. They can't tell you that something hurts or something doesn't feel right because they're unconscious. You need to look at them head to toe, front and back, and see if there's anything that gives you any clues to what might be going on. It could be an injection site, it could be a sting or an animal bite. Who knows? You need to assess your patients. Full body assessments will help you obtain clues and should be performed quickly so it doesn't delay your transport. I say we need to get physical with our patients and we need to touch them and we need to look at them. If they're conscious, you need to communicate with them first and ask them permission to touch them. Don't just assume that you can. And we always need to be respectful of the patient's privacy. If they're laying in the middle of the street, probably not a great idea to just cut their clothes off and make them naked in the street. Be respectful of that. On your physical exam, you're going to be examining the head, the scalp, and their face. Check the neck closely. Assess their chest and abdomen. Palpate legs and arms. And then examine their back. Vital signs. Assess their pulse. You're looking for the rate, the quality, and the regularity. Identify the rate, quality, and regularity of their respirations. Obtain an initial blood pressure. And consider a blood glucose level and pulse oximetry reading for every patient as well. Every patient that it's appropriate for. Your reassessment. So your reassessment is going to be performed once the assessments and the treatments have been completed. It's going to begin and continue throughout transport. And you're going to continually reassess the need for ALS backup. You're going to reassess need for additional interventions. And you're going to reassess whether the current interventions that you've already provided have made any changes in the patient's status. Any changes that you experience need to be documented. Most medical emergencies require a level of treatment beyond what's available in the pre-hospital setting. That might be something as simple as advanced testing, like blood work, for example. It may be beyond the scope of an EMT to administer medications to a patient. EMTs can use an AED on a patient who is pulseless and apneic. Your scene time. Your scene time might be longer for a medical patient than a trauma patient. There's a lot more questions to ask and a lot more decision making to do with a medical patient than there is a trauma patient. Gather as much information as possible and transmit it to the ED. Critical patients always need rapid transport. And again, that's any patient with an altered mental status, airway breathing difficulty, any sign of circulatory compromise, and very old and very young patients. If a life-threatening condition exists, your transportation should include lights and siren. If the patient is not critical, consider non-emergency transport with no lights and sirens. The mode of transport usually will come in two different categories, by ground or by air. To go a little more in depth on the lights and sirens conversation, every agency has different policies when it comes to this, but the most important part of this is to remember, if you're the driver, the way you drive, how you get to the hospital should be of utmost importance. If you are taking someone with a stub toe to the hospital, but it's almost lunchtime and you're hungry, it doesn't mean you can turn the lights and siren on. Every time you hit that button to turn those lights on, you need to remember that if you get into an accident and someone gets hurt or killed, you're going to need to justify why you turned those lights on. And if you can stand in front of an injured family member's family and say, this is why I had my lights on, this is why I was disobeying traffic laws, and you can feel good about that, then you're probably making the right decision. If you know in your gut that I probably shouldn't be doing this, but I'm really hungry, it's going to get you in trouble someday. Be cognizant of that. Make smart decisions based on the patient's true condition and whether or not they need to be transported that rapidly. Ground transport units, typically staffed EMTs, advanced EMTs, paramedics. Air transport EMS units are typically staffed by critical care paramedics, Most of these services will have critical care nurses as well. Destination selection. So we've talked about this a little bit, like especially with cardiac stuff. In general, the closest hospital should be your destination. Um, Sometimes the patient will benefit from going to another hospital. Use your discretion with this as well. If you have a critical patient and they tell you, well, I really want to go to this hospital that's 2 hours away, that's probably not feasible. You need to explain to the patient that we need to go to the closest hospital. You need to get treatment as soon as possible. We can't go that far away. Do what follow your agency's policies, follow your protocols for whichever state you're in, and make an appropriate choice for which hospital you're going to go to. And you can't kidnap patients, so you can't force them to go to a hospital they don't want to go to. Infectious diseases, general assessments, approach them like any other medical patient. Perform a good scene size up, take your standard precautions, complete your primary assessment, gather the history using OPQ or ST to elaborate on their chief complaint. Obtain your sample history and baseline vitals. Pay attention to medications and events leading up to the problem today. Ask whether the patient has recently traveled or if they've come in contact with somebody who's recently traveled. Excuse me. Patients that travel to foreign countries tend to bring things back with them. That's why that's important. General management, focus on any life-threatening conditions that you identify in your primary assessment. Be empathetic with your patient. Place the patient in a position of comfort on the stretcher and keep them warm. Use your standard precautions. Epidemic and pandemic considerations. An epidemic is when new cases of a disease in human populations substantially exceed what is expected. A pandemic is a disease outbreak that occurs on a global scale. Influenza. Patients with chronic medical conditions, compromised immune systems, and the very young and the very old are most susceptible to complications of influenza. It's transmitted by direct contact with nasal secretions and aerosolized droplets from coughing and sneezing. For any diseases that can be passed through the respiratory route, make sure you're wearing the right PPE, gloves, eye protection, HEPA respirators, N95 masks, whatever you have. We just went through all this with COVID. Put a surgical mask on the patient if you can do that. And flu shots are important. Herpes simplex is a common virus strain that's carried by humans. Symptomatic infections cause vesicles that will appear on the lips or the genitals. Can cause more serious illnesses in susceptible patients. And the primary mode of infection is through close personal contact. HIV infections. EMTs face a risk of exposure to the virus that causes AIDS on a regular basis. AIDS can still be fatal, however, with treatment, patients can expect a near normal lifespan. HIV infection is a potential hazard only when deposited on mucous membranes or directly into the bloodstream. It's not easily transmitted in the work setting, and your risk of infection is limited to exposure of an infected. Sorry, let me try that again. Your risk of infection is limited to being exposed to an infected patient's blood or bodily fluids. So if you're going to be exposed to this, you need to come in contact with their blood or their bodily fluids. Again, that's not happening in a typical work setting, but unfortunately for us, it happens more often. Many patients that have HIV will show no symptoms. Always make sure you're wearing the right type of gloves. Take care in handling any needles or sharp objects that you might have used for the patient. Cover any open wounds that you have on your body when you're working. And if you think a patient's blood or secretions may have entered your system, you need to seek medical advice as soon as possible and notify your infectious disease officer for your agency. Hepatitis, inflammation and infection of the liver. It can be caused by viruses and toxins. There's no sure way to tell which hepatitis patients are contagious. and EMTs are highly recommended to have a Hep B vaccination. Hepatitis A is transmitted orally through oral or fecal contamination. Hepatitis B is far more contagious than HIV. And hepatitis A will only be transmitted from a patient who has an acute infection. Hep B and C can be transmitted from long-term carriers who have no signs or symptoms. So there's a little table showing you hepatitis A through D, all their different routes, treatments, so on. Meningitis, the inflammation of the meningeal coverings of the brain and spinal cord. Most forms of meningitis are not contagious. Meningococcal meningitis is highly contagious. Make sure you're taking your standard precautions. Vaccines are rare. Meningitis can be treated at the ED with antibiotics. And after treating a patient with meningitis, contact your employee health representative if you think you might have been exposed. Tuberculosis. Most infected patients are well most of the time. It's a chronic disease that usually affects the lungs, occurs shortly after infection. It's called primary tuberculosis if it occurs right away. Reactive tuberculosis is common, but it can be more difficult to treat. Patients who pose the highest risk almost always have a cough. Consider respiratory tuberculosis to be the only contagious form because it's the only one that's spread by airborne transmission. These are the ones you've got to have an N95 or a HEPA mask. A typical surgical mask is not going to protect you from this. There is no absolute protection from this infection. A third of the world's population is actually infected with tuberculosis. And you should have your tuberculosis skin tests on a regular basis. Whooping cough, also called pertussis, mostly affects children that are younger than 6 years old. This is that whooping cough sound. There's a vaccine for this. If you experience a patient that has it, put a mask on them, put a mask on yourself. MRSA. It's a bacteria that causes infections. Sorry, weird stuff is happening on my screen again. Every time Matt shows up, weird things happen. I don't know what's up with that. MRSA is resistant to most antibiotics, and MRSA is transmitted patient to patient by healthcare providers' unwashed hands. This stuff runs rampant in hospitals and nursing homes and stuff like that. Increased risk of MRSA, antibiotics, prolonged hospital stays, ICU and burn units, and exposure to infected patients. MRSA ultimately results in soft tissue infections. COVID-19, it originated in Wuhan, China. Spreads quickly. It infected millions, killed hundreds of thousands of people. Best way to control it is social distancing. You're going to see fever, cough, shortness of breath. Yeah, I think we've beat COVID-19 to death. Middle East respiratory syndrome coronavirus. First human case was in 2012 in Saudi Arabia. There's no cures, no vaccines for this. If you suspect it, put a mask on yourself and the patient. Ebola, this was big in 2014. Came from West Africa. Incubation period is 6 to 12 days after being exposed. You may not see symptoms for up to 21 days. Fatality rate can be as high as 70% if treatment is not initiated promptly. Travel medicine. Again, patients travel outside of the U.S., bring weird stuff back with them. Be aware of that. They can have a variety of symptoms. If they've traveled recently and they have any kind of sickness, you should put a mask on them just to protect yourself and them. questions to ask for people that have traveled recently. Where'd you go? Did you get any vaccinations before you went? Were you exposed to anything while you were there? Is anyone else that traveled with you sick? What type of foods did you eat while you were there? And where'd you get your drinking water? So your assessment and treatment of medical patients can be challenging, can be interesting because of the different nature of the medical conditions. Um, the condition of a medical patient may not be as apparent as it is with a trauma patient, and there might be more than one problem going on. So we've hit the review. Um, what kind of emergency is a seizure patient having? C, they're having a neurologic emergency. If an injury distracts an EMT from assessing a more serious underlying illness, the EMT has suffered from what? Good. Tunnel vision. Well, I just gave that one away. If a frequent flyer calls 911 because of a suspected head injury, you should never do what? Amazing. Everyone got that one right. We talked about that. I gave you my little story. Don't label them. Don't develop biases. You've got to treat them the same way you would treat every other patient, no matter how many times they call, no matter how silly it might seem like their complaint is. Treat them the same every time. It's very important. A medical patient is not in critical condition. How long should you spend on scene? Good. D. They're not going to dictate how long you spend on scene. Take as much time as you need to get the relevant information, but also don't spend too long there. You still need to get to the hospital. The patient is having respiratory difficulty and is not responding to your treatment. What is the best method of transport? Good. B. With lights and sirens. That's one of those. They're not responding to your treatments. They need to get there quick. Use your lights and sirens. When assessing a patient with an infectious disease, what is the first action you should perform? Remember, this is another one of those silly ones where they want to make sure you're following the process correctly. So what was the first step of every patient assessment? All right, I like it, Cyrus. Cover your mouth with your hands. Correct answer is A. Start out by seeing size up. Did it again. That's interesting. There's an answer before a question. Well, I gave it away because the answer is before the question, but Your patient believes he has hepatitis and is now exhibiting signs of cirrhosis of the liver. Which hepatitis does he most likely have? Cirrhosis of the liver develops in 50% of the patients who have hepatitis C. Answer is hepatitis C. Matt, we're not making up hepatitis. There's not any yet. Your patient's complaining of fever, headache, stiffness of the neck, and red blotches on his skin. What does he most likely have? Very good. D. Most likely meningitis. What should you do when you're exposed to a patient who is found to have pulmonary tuberculosis? Good. B. Tuberculosis, they give you that little skin test where they implant something under your skin, and if you don't have a reaction within a few days, you're all set. All the following are factors that increase the risk for developing MRSA, except for what? Good. D. Nothing to do with birds and MRSA. All right, that's that. We covered a lot tonight. Anybody have any questions? Give me a thumbs up if you're good. Perfect. All right. Quizzes should be posted. If they're not, we'll get them done in the next day or so. So make sure you're getting your quizzes in. And I believe you have class this Sunday. You do. You have class this Sunday. So we'll be in Tamworth at the training center on Sunday.